morning, everyone. My name is Kathy Hopkins, and I coordinate the webinars for Houseman Johnson Insurance. I would like to welcome you to today's webinar, An Introduction to Healthcare Data Analytics. Today's webinar will run for the full hour. If there is time after the presentation, we will have a question and answer session with Matt. If you have a question during the webinar, feel free to type it into the question feature and Matt will address it. After the webinar is over, there will be a short survey we are hoping you can fill out for us to give us feedback on the webinar and webinar topics you are interested in learning more about. Feel free to share your thoughts on LinkedIn or Facebook and tag Houseman Johnson Insurance. This webinar will be recorded and will be available on the webinar archive section of our website. Each attendee will also receive a follow-up email with a link to the recording and the presentation slides. I would now like to introduce you to our presenter for today's webinar, Matt Weimer. Matt joined BSG Analytics in February of 2017 after managing the IS team at Integrated Health Network. He is a seasoned data professional with over 15 years in IT and data analysis. He achieved his MBA from UW-Milwaukee in 2010 and has combined leadership, management, analysis, innovation, and technology in order to lead teams in both the dental and medical industries. We are happy and thankful that Matt can be with us today to share their expertise and answer our questions on data analytics. Welcome, Matt.
Good morning. Thank you for joining us today. My name is Matt Weimer. I am the Director of BSG Analytics. And today we are going to dive into an introduction to healthcare data analytics, and more specifically, how BSG Analytics approaches healthcare data. So we begin today by looking at the iceberg example or illustration that shows the simplicity versus complexity. Many times when we think of simplicity in the data world, we think of just data reports. Data reports many times come directly from the carrier or insurer, and they are already rolled up or summarized. They are usually based on diagnosis codes and are very transactional, cost accounting, and unit price based. And the benchmarks are community-based, are based on communities and book of business. BSG Analytics likes to dive a little bit deeper and in order to get a better informed decision making. So we try to go beyond just the simplicity of data reports. And we like to apply data science and or deep dive analytics. We're going to brush on a few subjects initially here, but we will dive into them a little bit more in greater detail in terms of the definitions and some examples. So we like to get the raw data from our clients, from health systems, and from carriers or insurers, and put that data into our data warehouse. The reason for that is we are then able to create major practice areas, which eventually roll into episodes of care that ultimately help us get to the total cost of care. And our benchmarks are a blend of commercial and proprietary benchmarks that focus on populations, national, regional, and local. So for our proprietary data warehouse is SQL Server based. We have the capacity to intake or consume really any of the typical data feeds that we would see. In terms of a health system sending clinical data, those are called HL7s. A health system sending billing data to a carrier or a consultant would be an 837 file. A payer or insurer sending data is called an 835 file. So we have the capacity to consume all of those different files into our data warehouse, as well as some of the standard formats that many people are familiar with. For example, Excel, XML, and CSV. Our data warehouse then feeds multiple analytical environments where we lay proprietary custom products on top of, as well as a ClickView environment in which we like to call internally iterative discovery, and that is also our presentation layer. The reason why we like to get the raw data and create a data warehouse is so that we can create major practice areas. Those provide increased clarity, accuracy, and the ability to connect utilization and demographic data in a meaningful way to clinical pathways. And again, we'll show you some examples of these a little bit later in our presentation. Ultimately, what we try to get to is the episode of care, the longitudinal look at the illness burden. It provides a full picture of the illness burden. We can get to things like the appropriateness of care, clinical pathways, sequence and timing of care, and the total cost of care metrics. It also allows us to get insight into the participant or patient engagement, and it allows for us to compare providers as well as health systems. The episodes then get rolled up into what we like to call ETGs, or episode treatment groups. These are basic illness classification methodologies. They group claims into meaningful episodes of care. It captures relevant services provided during the course of treatment. Episodes are clinically homogeneous regardless of treatment location or duration, and they are severity adjusted to reflect relevant complications and comorbidities. The types of claims that are incorporated into the ETGs are listed on the right: inpatient, outpatient, professional, ancillary, and pharmaceutical. An example of this would be if, let's say just for instance, you're playing basketball with your nephew and all of a sudden you feel a twinge in your knee. The next day you realize that it hasn't healed, so you set up an appointment to see your primary doctor. That is a professional claim. The doctor might order an MRI. If you go to get the MRI would be considered an outpatient claim. If the MRI came back with results that said that you needed to have your ACL or MCL repaired and you needed to have surgery, that typically falls under the outpatient category. However, if there were complications, you might have to be admitted, and that would be considered an inpatient claim. And then lastly, the pharmaceutical piece, or what we call RX, you might need some help with the pain, so they might prescribe some medicine. So those are all examples of the types of claims that we would include in an episode and ultimately in an ETG. Here's an illustration of the hierarchy. So we start at a very high level of major practice categories. There are 22. If we wanted to drill deeper, we could go to the base ETGs, which there are 524. And if we wanted to go to the most granular level, we go down to the detailed ETG, which there are over 1,500 of. And we can also divide those into 4 levels of severity. And the severities are based on member demographics, episode complications, episode comorbidities, and the complication and comorbidity interactions. And so here's an illustration of the hierarchy of what it might look like. So if we look to the left, we have 22 major practice categories. Those align with the clinical pathways. So you can see there's cardiology, there's rheumatology, there's preventative, urology, etc. For this particular example, we're focusing on endocrinology or endocrine. We want to drill down to patients that had diabetes episodes. And then you can see on the right, again, there's over 1,500 combinations, but we can look at patients who had diabetic episodes with or without complication, with or without comorbidities, and with or without surgery. And again, we can get to, in most cases, 4 levels of severity. The episodes of care also allow us to compare physicians, and this is an illustration of why it's important to look at the full episode of care rather than just a claim. So if we're comparing physician A to physician B, there's a couple of things to illustrate. These patients have been diagnosed with pneumonia. The first thing is that if we were to base our care on the price of just the office visit and the x-ray, physician B comes out ahead. The total is $180 versus $220 for physician A. That's a difference of $40. However, if we look at the full episode of care for the patient with pneumonia on physician A, we notice that physician A has what most likely amounts to a care coordination or a population health program that followed up with the patient, that made sure that the patient was taking their antibiotics, getting lots of fluid, and getting lots of rest. And as a result, the follow-up visit deemed an outcome that the patient was healthy and the disease was gone. Physician B did not have such a program, and therefore on the follow-up visit, it deemed that they needed to be admitted into the inpatient facility. Therefore, the total cost of care for the same disease is much greater for physician B as opposed to physician A. So it's a great example of why we can't look at just the claims in order to make our decision on where to seek care. And I think we have a short video coming up here that illustrates this point even further. So again, that video kind of illustrates why we need to look beyond the unit price or a point in time in care, and that we have to look at the resources or costs applied to the longitudinal look of the illness burden. And then lastly here, our population-based benchmarks. Again, we blend commercial and proprietary benchmarks that provide increased precision and accuracy to the region or the industry in which the employer works. It helps align with clinical reality, and we help to provide social, behavioral, and cultural determinants. So at the end of the day, each of these different approaches to data help us improve the quality of decision support through better quantification of the drivers of cost and the identification of actionable opportunities over current reporting practices. So, to kind of deep dive into that a little bit and provide an example, medical billing is based on ICD codes. ICD codes are essentially the diagnosis codes. It's how a doctor diagnoses a patient and allocates or decides what disease the patient has. Typically what you see on many carrier reports are that only 4 ICD codes are used to classify diagnosis and to pay bills. Virtually all carrier TPA claim reports are based on these 4 ICD codes. So if we were analyzing a population based off of this data set, we can calculate a risk score that we see at the bottom as 0.63. We can also create a tree map of the prevalence of disease of our population. So the tree map is a top-down approach. We notice that the first one is factors influencing health status. This is an ICD code that was added at the latest version and is more of a general category in which we would have to drill down further. For the purposes of this demonstration, I want to concentrate on the next two. So if we were creating a disease management program, we would want to focus on the diseases of musculoskeletal and the laboratory findings based off of the data set that we have. However, our data has shown, and our research has shown, that 71% of all medical spend is for patients with chronic conditions. What if the typical reports don't account for all patients with chronic conditions? 40% of chronic conditions are missing when only the first 4 ICD diagnoses are used. So essentially, the system that was designed for medical billing has become the same system we use to manage and deliver medical outcomes and to analyze data. This can be fundamentally flawed. So, BSG Analytics approach is to receive the raw data feeds where we request as many diagnosis codes as possible, and many times we can get up to 10. This does a couple of things to our population. First, it increases the average risk score of our population by nearly 33%. Additionally, the disease prevalence has now changed from musculoskeletal and laboratory findings to endocrine, which is many times considered the diabetics, and the circulatory system, which is the heart. So if we wanted to create a disease management system, we would want to focus on those 2 factors first, rather than the musculoskeletal and the clinical laboratory findings. Correctly assessing a patient's needs for a successful medical outcome many times requires more than 4 pieces of diagnosis data. Moving on to a case study in diabetes, this is an actual transactional claim report that when we compare this particular client's diabetics to a benchmark or market, what we're saying here is that the client is 20% under the benchmark for diabetes. When we create an analysis, 1 is normally the market or the average. So when we see 0.8, we see that this particular client is performing 20% better than the market or the average. However, carrier and other transactional reports show the total claims for a diabetic, not the claims for treating the disease of diabetes. Okay, so when we look at the cost of actually treating diabetes, the employer is actually spending over 20% more than the benchmark. So what we would do is we would create episodes of care. We would then compare those episodes of care for the disease diabetes to an average or a benchmark. And we can see that the medical surgical or the client non-RX is actually performing very okay compared to the benchmark. However, their additional spend is all on the RX side. The other benefit of running the episodes is we can get to a risk score. So if you notice that next to the diabetes here, it says 1.05, that indicates that the population that this client is managing is actually 5% higher than the market, 5% riskier than average. So when we dig even further, we find that some providers or health systems are much better at managing diabetes than others. So again, these are rolled into episodes of care, and we're comparing the med-surg amounts and the pharmaceutical or RX amounts either to a market average or a benchmark. Over on the right, we have the severity score, which indicates the risk of the population that the health system is managing. So we first want to highlight providers number 4 and 8. The first thing that we see is they have very mild cases of the disease that they're being managed. However, the costs associated with their population is much higher. The excess costs appear to be concentrated on the RX spend. So while the med-surg benchmarks are in line, they are prescribing much more medicine than the average or the market. Additionally, provider 7, while cost is still higher than expected, it is a good result for the severity presented for those diabetics. So in other words, they are managing a much riskier population, and they are actually managing them rather than assigning out scripts. So, in short, for provider 7, they're devoting considerable extra expense to medical expenses. What that means is they most likely have a population health or a care coordination program where they're following up with their diabetics, making sure that their A1C are falling in line, that they're getting their blood pressure checked, and that they're going to see their primary physician regularly. In the case of the extra office visits and lab tests is related to the management of the disease. So studies show that providers will have patients that will have better control of the disease and fewer large claims in the future. So they're spending more in the near term to make sure that their patients are healthier and that the spend is less in the long term. So again, here's kind of a drill down look of what we were talking about. So initially, we start with a very high level transactional claims data report. We then, through our analysis, we are able to create episodes of care. We're able to get to the risk of the population per the client, and we can see the chronic conditions by episode. We can also get to the health system. How risky is the population that the health system is managing? And then what is their med-surg and pharmaceutical spend versus either a benchmark or the market? And one of the last things we want to share today is our total cost of care dashboard. It's really a dashboard that helps us measure healthcare value. And so in healthcare, these are the key measures and the key indices that we use to help kind of assess how a health system or a provider is performing in the marketplace. So when we talk about healthcare, we obviously want to have as high a quality as possible, better outcomes, healthier patients. We also want that to be efficient. We want you to use, or we don't necessarily want, but you should be using as few resources and being as efficient as possible to provide that quality care. And then, of course, there's unit price. How much do these things, or how much do these services, how much does it cost to treat the diseases? And then population health. Do you have, a care coordination? How are you managing your chronic condition patients? And then employee and patient engagement is also very important. So we obviously want to manage our patients as well as possible, but we also want to see are they going to their follow-up visits? Are they doing the prescribed amounts of what the doctor prescribes? And really that helps us to get to our total cost of care, or our total value of healthcare. And you can see that we also added weights. So this is per our research. So when we do create our indices and we pull our data, these are the weights that we assign to each category. And so just a quick summary here. So in short, we seek to, here at BSGA, dive a little bit deeper into the data in order to have better informed decision making. That's really what our main purpose here is. We take an approach that is critical to proper identification, classification, and quantification of the cost drivers. And then we use data science and other analytical approaches that require more robust analytical, clinical, and consulting expertise than most agencies possess. Episodes of care really help us spotlight the risk of our population, clinical and financial comparisons of providers and health systems, and participant behaviors, which allow for richer programs in market-driven communication. Thank you. Open it up to questions.
Yeah, so if you have any questions about what we've just gone over, you can ask Matt anything. Just type it into that question feature on GoToWebinar. So I see we have a couple questions. So the first question is, what data do you use to perform this type of analysis?
Yes, that's a very good question. So we use a combination of both commercially available and some proprietary data. At the end of the day, what we seek to do is combine quality level data, efficiency level data, social determinants in order to get to the total cost of care. So it's a combination. We are actually in Wisconsin, so we have the ability to get to the quality data through things like CMS, our collaborative, WCHQ. We also have an all-payer claim database that is commercially available in Wisconsin that we utilize. And then we also have some proprietary data that we work with clients on improving their outcomes and essentially improving the efficiency of the way they deliver healthcare.
That's a great answer. It looks like we've got another one. So what are some specific scenarios and instances that you can think of where using data analytics actually reduced cost?
We actually have a PDF that we can send out after this meeting, and that actually provides several examples of instances where we use our data and episodes of care to help identify areas where the costs were very high or the utilization was very high, and we can send that out directly after this meeting.
Yeah, we will definitely include that along with a copy of the slides. Well, it looks like we might not have any more questions. I'll leave it open for a couple more seconds. All right. Well, we want to thank you guys so much for attending today's webinar. As a reminder, please fill out that short survey sent to you. Your feedback is incredibly important to us, and we'd love to hear from you. We'd also love your feedback online. If you'd like to leave us anything on LinkedIn, Facebook, just remember to tag Hausman Johnson Insurance. And we hope you can join us for our next webinar on May 16th, which is how to write job descriptions and why you need them. You can sign up for our upcoming webinars on the Hausman Johnson website. And again, I want to thank you so much for attending and hope you have a great rest of your morning. Thank you.